We'll start the recording. And I'd like to introduce Dr. Cynda Rushton, as she will be our guest speaker tonight. Dr. Cynda Rushton, she's an international leader in bioethics, is the Anne and George Bunting Professor of Clinical Ethics at the Johns Hopkins Berman Institute of Bioethics and the School of Nursing. She co-chairs the Johns Hopkins Hospital's Ethics Committee and Consultation Service. She's a founding member of the Berman Institute. She co-led the first National Nursing Ethics Summit that produced a blueprint for the 21st century nursing ethics. She was a member of the National Academies of Medicine, Science, and Engineering Committee, and she is a member of the American Nurses Association Center for Ethics and Human Rights Ethics Advisory Board, and the American Nurses Foundation Wellbeing Initiative Advisory Board. Dr. Rushton is the Chief Synergy Strategist for Maryland's R3 Resilient Nurses Initiative, and she is a Hastings Center Fellow, Chair of the Hastings Center Fellows Council, and a Fellow of the American Academy of Nursing. She is the editor and author of Moral Resilience, Transforming Moral Suffering in Healthcare. Welcome, Dr. Rushton, to the virtual stage.
Thank you so much, Lou, and thank you all for inviting me to be part of this. And just want to pick up with where Dr. Mabagwu, I probably said your name not quite right, but
no, you got it.
Okay. I want to pick up where you left off, and that is to pause, because I think there's no question that has been a time of real challenge for every single person. I don't think there's anyone who's really made it through unscathed. So just to pause for a moment and to remember the service that you've provided over this last year, the things that you have done that have made a difference, the ways that you have shown up again and again, the challenges that you've met, the ways that you have cared for others. And also to remember how many people have lost their lives as a result of this virus. This is an installation that was on the mall not long ago, and each of these tents here really represent a life. And so just for a moment to consider, more than 745,000 Americans' lives have been lost in this pandemic. Some of them have been your neighbors, some of them have been your friends, some of them have been your family members. And some of them have been patients and people whose names you never knew. And yet, this has been the reality for all of us for the last 20 months. So just to pause, it's easy to sort of lose track of why we're here. And I think as nurses, it's clear why we're here. So just to take a moment to kind of connect to why you're here and why your service makes a difference to so many people. So I wanted to start by giving a little bit of context for what this year has been like for many nurses. There have been incredible examples of compassion and courage and self-sacrifice beyond what anyone could expect of a human being. And there have also been many new challenges. And in my work, focusing on the sort of values and ethics that undergird our work in healthcare, think about all the ways that nurses were put in the position of having to pivot, to innovate, to make new choices about how to practice, sometimes not voluntarily. And if you think about what happened in the beginning, we didn't have enough things like PPE, and often the result of that was decisions were made that we had to limit the number of people that could go into the room of a patient. And often it was the nurse taking on additional risk to his or her own health and being the eyes and ears for the entire team while other people stood outside the door. We learned how to write backwards and to communicate through the window inside the isolation room. We learned how to deal with the new challenges that came with the fact that we couldn't have family members present, particularly when patients died. Nurses were the ones who figured out how to increase family engagement. And so when you think about that, all in the context of scarce resources, many of us have never had to confront the volume of patients or the scarcity of resources that were present during this pandemic, and actually continue in some areas of the country today. So with that, there were a number of ethical questions. How do we allocate our scarce resources? How do we actually provide quality, safe care? How do we deal with the crush of grief that so many of us have carried during this time? How do we actually make sense out of all these important questions that in some ways, our ethical questions were more episodic before. You had a difficult case, but then there was a period of time where things kind of plugged along. What's happened now is the ethical issues are front and center. They are part of every single day, and they are chronic and often unrelenting. And of course, in the context of the societal and social unrest that was unleashed again and again as we watched people of color be put in situations where they were killed at the hands of law enforcement, where we saw in a daily basis the inequities of our healthcare system and our society that left people of color in particular at risk for contracting the virus, of being able to benefit from the treatments that were available. And all of that, I think, intensified when you think about the great division in our country. So it's not as if our healthcare experience is separate from all of that reality in our communities, in our society, and in our world. And so when you think about that, all of that was intensified during this last 20 months. It was not the case that you could sort of excavate yourself from it. It was present every single day. And I think what happened with that was there was a lot of moral adversity. The sense of having internal or external constraints that prohibited us from doing what we thought we ought to do, but also engaging in actions that produced some kind of negative moral outcome. And in the end, it compromises our sense of integrity, either individually or collectively. And if you think about our profession right now, I think the accumulation of this moral adversity has really left a heavy weight on all of us. So just to think for a moment for yourself of what kinds of moral adversity have you faced in your work and life over these last 20 months? And often these kinds of experiences stay with us. They're not the ones that we're easy to sort of let go of at the end of the day. They stay with us, and they do accumulate over time. For many people, the experience in response to different types of moral adversity has been all types of moral suffering, which is anguish that we experience in response to moral harms, wrongs, or failures, or unrelieved moral stress. And what's important to realize is that it can be activated by witnessing what someone else is doing. It can be activated by participating in something we think is wrong, or actually causing harm to others. And so when you think about that, there is often many ways that moral suffering shows up. And in our work, we try to think about it in the context of moral adversity as sort of the instigator, the trigger, if you will, that imperils our integrity in some way. And initially we might experience this as a kind of moral stress where we realize, wow, there's competing obligations here. How do I make sense out of this? More commonly, and the type of moral suffering that's been most studied in the literature is moral distress, where you recognize a moral problem, you have some responsibility to do something, but you can't do the right thing. What we've come to realize during COVID is there are even more corrosive types of moral suffering in the form of moral injury. And moral injury is a concept that was really first described in the military. It's a profound distress that results from actions or lack of actions which violate a person's moral or ethical code. So I want you to pause on that for a minute and think about ourselves as nurses and our code of ethics and the times where we may have felt that we have violated what our code outlines as the behaviors that are expected of a nurse. So this moral injury can be personal. It can also be collective. And I would say that what we're seeing a lot of is a collective kind of moral injury. What we also know from the military is that it occurs in high stakes situations. So if you think about what's happened in COVID, high stakes for sure. But what is also a feature of moral injury is that often people don't even realize it until after the fact. So if you think about the COVID experience, people were rushing in, trying to do whatever they could to treat the people who needed care. And it isn't until there was space where you paused and you said, wow, is that really what we did? Is that really what happened? That we begin to realize that there have been severe transgressions or betrayals that have happened, and sometimes by people who are in authority. The consequence of moral injury is that it begins to dismantle our moral identity. It damages our moral fiber of who we are and challenges our sense of worthiness as a person. So this kind of moral suffering, I think, really is a type of moral suffering that we're beginning to understand a little bit more. We're seeing data now coming out about the experience of nurses and others in terms of moral distress during the pandemic that was present before. Many of those factors are related to things like scarcity of resources, working with colleagues who were not skilled enough or were unsafe. And if you think about how many people were redeployed, that's not surprising at all. Lack of resources and risk to our families. Sorry, my mouse is jumping around here. But what we've also seen is that the prevalence of moral injury is also worrisome. So early on in the pandemic, a study that was done in Japan, the prevalence was about 20%. We did a study during the pandemic of nurses and physicians and other healthcare workers, and our prevalence was 32%. But nurses had clinically significant symptoms of moral injury, 38% of them. That's astounding when you think about the consequences of moral injury, because it is highly correlated with PTSD and depression. It's highly correlated with burnout and medical errors and suicidal thoughts. What we know from a mental health point of view is that these data around the impact of mental health outcomes on nurses are really very worrisome. We also saw in the data that there was a significant increase in moral injury scores for those who were actually taking care of patients with COVID. In our own work, we looked at some factors in the organization that we thought might be contributors to these moral injury scores. And what we found is that when the ethical concerns score were, the higher they were, the higher the moral injury symptoms. And so some of the ones that were particularly correlated were in situations where people perceived that there were negative consequences if they spoke up, where they had limited resources, when they were implementing the decisions of others that threatened their own values. You can imagine how that might be happening. Another one was losing their ability to advocate for their individual patient because of resource constraints, making decisions to limit or forgo treatment without their surrogate's usual involvement. And the other one that was highly correlated was being infected yourself by performing your roles in the hospital. So what we saw was that the consequences are really significant. And as you look at these words here on this word cloud, you might be able to recognize some of the consequences of how we respond to our moral suffering. You know, in the beginning, there was a kind of sadness. There was a sense of, I tried harder. Who am I letting down? I've had so many conversations with nurses who have said, could I have done more? And I always want to just take a breath when I hear that of, really, could you have done more? Is that really even a true or realistic statement? But what we also see now is a lot of anger and a feeling of numbness and feeling that, you know, when you consider all that people have carried, this image really, I think, represents what many nurses have felt, you know, this sense of carrying so much on their back every day. So this moral residue that persists even when we've done the right thing is what tends to accumulate when we have been in these situations that compromise our values. It ignites a feeling of guilt and shame, regret, and remorse. And often what's also true is that many people hold themselves accountable for things that were beyond their control. And so pretty soon, the residue from these circumstances really begins to accumulate and gets expressed often in moral outrage, which is the expected response to a violation of an important moral principle. But it also, not so much, I would say, in healthcare, but if you think about our broader society, in a kind of moral apathy, when denial, lack of caring, or willful ignorance makes it possible for us to ignore or not perceive the suffering of others. So when you think about that, those are consequences and responses to our moral suffering. And these are just a few images that were created during the pandemic. Many nurses felt as if, you know, on the one hand, everybody was clapping and cheering, but every day they felt like it was death by 1,000 cuts. And other nurses talked about feeling as if they were drowning under the water, trying to hold up the patients that they were meant to care for. And this last one that was created by a nurse in California, Molly McQuinn-McCann, she said it was like being underwater and gasping for breath, is how she felt about her day-to-day work. So it's important for us, I think, to acknowledge that all of that is true. It is not helpful for us to pretend that that reality is not true. But as His Holiness the Dalai Lama says, it's important for us to also recognize that when we meet real tragedy in life, we really do have two options. One is by losing hope and falling into self-destructive habits, or using the challenge to find our inner strength. And that was really what motivated me about 5 or 6 years ago to pivot from the suffering side of the equation to asking, and what else is possible? And so this began our work in the concept of moral resilience, which is the capacity of an individual to sustain or restore integrity in response to some kind of moral adversity. It's not an appraisal of whether you are either moral or resilient, and it certainly is not about being complacent or overlooking the very real challenges that are present in our world, or just putting a positive spin, like, the difference between hope and optimism. Optimism is, oh, it's going to turn out all right. Hope is a realistic appraisal and choosing to orient toward that possibility despite the challenges. So when I think about this concept of moral resilience, the image that I like to use is to use this practice that is done in Japan. It's called kintsugi, where a piece of pottery is broken. And instead of throwing away all the pieces like we would here, it's like no longer useful, they would take those pieces of pottery and very carefully and mindfully put them back together using golden paint and cement to honor the broken parts, to be able to put this vessel together in a new way that is more beautiful and perhaps even more stronger as a result of that experience. And so when we think about moral resilience, we think of it as a strengths-based orientation. It is not a deficit model. We assume that people have that inherent potential within them, and that we can actually activate and amplify what's already there. Being good researchers, we did some research and we came up through qualitative analysis of 6 elements that are part of moral resilience: personal and relational integrity, buoyancy, self-regulation and awareness, moral efficacy and competence, and self-stewardship. And from that, we developed a scale to measure moral resilience. And we've now used it in a couple of studies. What we're finding is that as scores increase in moral resilience, moral injury symptoms decrease. We also, in a separate study, have seen the similar pattern with increases in moral resilience scores and moral distress, as well as decreased mental health outcomes, such as stress, anxiety, and depression. And as well, that as moral resilience scores increase, burnout and turnover intention also decrease. So what this tells us is that moral resilience may be a protective resource to help people meet these challenges in ways that don't leave them completely degraded or hopefully feeling as if they have compromised their integrity in some way. We mentioned in the beginning the most comprehensive collection of our work is in our book. So if you're interested in that, that's where you'd find that information. But when you think about this concept of moral resilience, it really starts with integrity. And so when I think of integrity, integrity is that place of being whole and undiminished. And when you think about where that starts, first of all, we have to know what we stand for. And when you think about what you stand for, it's different than what you stand against. Because when you engage with what you stand for, there's energy that's liberated. So for example, you might say, I stand against racism. I stand for justice. And by orienting toward the principle of justice, it gives us a kind of orientation that's not defensive, but actually liberates energy. Integrity requires us to live our values, not just talk about them, but actually be them in the moment, to be curious and to inquire, to discover what will actually serve, not allowing our ego to take over about what we want, but discovering what will serve. Asking hard questions and speaking out for what we stand for. Listening to the call of conscience, that inner voice that alerts us to things that need our attention when our values are challenged or compromised. And an important part of integrity is knowing and honoring our own limits. Self-knowledge of what our boundaries are and how we need to nourish ourselves is part of integrity. Taking principled action, or in some cases inaction, and being responsible and accountable. So when you think about these elements of moral resilience, it's not just myself alone. It includes relational integrity, the acknowledgement that our integrity is all intertwined, the sense of buoyancy that we have the ability to meet these challenges in ways that don't overwhelm us, that we use skills like self-regulation and self-awareness with things like mindfulness to develop the neural pathways so that we have a stable nervous system when these challenges and moral adversity arise, that we have the skills of moral reasoning and recognizing ethical issues, having ways to think about them, tools to discern what would be the right path. But one of the most important parts of this, I think, is self-stewardship. Self-stewardship is the commitment to know ourselves, to know our limits, and to turn toward them with compassion rather than judgment. To know when we need to step forward and when we need to step back, and be willing to invest in our own well-being. And if you doubt that that's important, take a look at the 5th provision of the ANA Code of Ethics. The nurse owes the same duties to self as to others, including preserving integrity and well-being. So one of our colleagues, Jen Simmons, who is an incredible ICU nurse who participated in a program we've been implementing now for about 5 years, the Mindful Ethical Practice and Resilience Academy, said this: "We are all resilient and courageous. Sometimes we just need tools and support to help us access what's already inside of us." So I want to just talk for a moment about the many doorways, that there is not one recipe, that if we could discover it, that would make all of this go away, or that we would be able to be restored to our previous state. I hate to tell you, I don't think we're going back. I think we can only go forward. And so when you think about those possibilities, I wanted to just share for a moment about our Resilient Nurses Initiative, our R3, Renewal, Resilience, and Retention of Maryland Nurses. And you see here my incredible colleagues who are part of this journey with me. We were fortunate to get an NSP2 grant. We're beginning our 2nd year. And this is a grant that focuses really on engaging 8 schools of nursing and 5 hospital systems, as well as our nurse residency consortium and collaborative. And you see here our coordinating council, the 8 schools and hospital systems that we're collaborating with, our National Advisory Board, and our Nurse Residency Collaborative. This is a project that is really aimed at, first of all, developing in schools of nursing a cadre of faculty who are, first of all, immersed in exploring the issues of resilience and ethical practice themselves, and then to be able to deliver specific tools and resources in their existing courses to build resilience and ethical practice skills in our nursing students. Because what we know is that despite our best efforts to train nurses, many of them are leaving after a very short period of time. And so we are approaching this by building some capacity within our faculty. Faculty are also exhausted, and helping them to be able to embody resilience and integrity themselves so that they can be role models for students. So our second workshop will be focusing on delivering a number of skills and tools. And then our third piece is actually turning toward the system and looking at the School of Nursing systems and trying to identify what some of the factors in our School of Nursing cultures that may be actually undermining the well-being of both students and faculty. We're also working with our NRP collaborative and doing work with NRP educators to help them to deliver some of these skills to nurses who are entering into practice. And we've created communities of practice among our faculty and our NRP educators. And it's just been a thrilling process to see. We have over 50 champions now who are working with us in this program. And we are really delighted to see the level of engagement. One of the things we did early on was we used a crowdsourcing platform, a Wiki Wisdom forum, which we had used for another project early in the pandemic to get nurses' views about how to address the issues that had arisen because of the pandemic. And we asked nursing students, nursing faculty, and nurses who orient and train nurses in practice where the gaps were. And what we came up with was this report called Mind the Gap, Preparing Nurses to Practice with Resilience and Integrity. And this is just a thumbnail sketch of the suggestions that came out from the participants themselves. The first was they wanted to modernize the curricula that reflected the 2021 realities. They wanted more exposure to practicing nurses. They wanted more content in ethics and ethical decision-making. They wanted more support systems for students and new nurses, not surprising at all, and to strengthen the connections between students and experienced nurses. One of the comments was, you know, we don't want to be protected from the reality. We want to know what it's really like to be a nurse and to be in the situations that we will definitely have to confront. And one of their recommendations that I highlight here is support for the whole student. And their recommendations here was to teach students how to advocate for themselves, to teach them higher order communication skills because they recognized how important it was to be able to articulate their concerns, but also to deliver them in ways that could be heard. They wanted to experience and to see other nurses and faculty to demonstrate their own self-care and self-stewardship. And related to that, these last two, I think, are particularly important when you think about how competitive our programs are. They wanted help as for students and new nurses to accept their human limits. And I want you to think about how hard that is for us as nurses. We press on, we press on, we press on. And so how do we help students to be good stewards of their own resources? One of the things they wanted more experience in was how to deal with mistakes and failure. And so in some ways, I think these recommendations give us some clues about some places where we might want to put some more emphasis in preparing students, both in their pre-licensure programs, but also as they enter into practice. One of their big recommendations was that they wanted a mentor from the first day of nursing school that would accompany them throughout their training and into practice. They wanted to start this process on the first day of nursing school, not in their leadership course in the last semester. They wanted to start practicing how to develop their own self-stewardship and all their skills to address these ethical challenges. So we, back in May, did a Mind the Gap Facebook Live event, and we had an incredible panel that included some of our participants in the development of that report. But I recommend it to you to think about, how do we begin to create a continuum for students and for nurses in practice to be able to sustain themselves over their careers. So I really am resonating these days with John Lewis and his wisdom. I think it's really easy to get kind of discouraged and to feel as if there's, not a lot of hope out there to turn this bus around. But I actually believe that we are in a position right now where we're poised to dismantle some of the systemic contributions to the impediments for healthy workplaces and also to create healthy learning environments for students. So I want to end with this quote by John Lewis. Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get into some good trouble, necessary trouble. So I would love to hear your thoughts and to see what kind of good trouble you want to get into. We would love for you to be part of our Resilient Nurses Initiative and help us to, really gather all the wisdom out there so that we can actually share it with everyone, so that we can all work together to find some solutions to these very real problems that are so present right now. And I do think it's going to take all hands on deck to be able to meet these challenges at this time. So I'm going to stop there.
Thank you, Dr. Rushton. This is Carol. I am manning the chat on behalf of DNA 5. And there's a question, or question and answer period. The first question is from a representative of Prince George's Community College. As a matter of fact, I'm going to stop the recording now so that people will be free to ask their questions. So let me just